All right, guys, so we're going to pick up on the last part of chapter 35. This right here, we're just kind of going to go over, excuse me, baseline treatment and differentiation, so to say, and how to treat specific types of shock. So we're going to pick up with resuscitation. It's on page 1322. So resuscitation of a patient who is experiencing shock is aimed at restoring adequate peripheral tissue oxygenation as quickly as possible. Sometimes to do this, the paramedic must ensure that one, adequate oxygenation is available, maintaining an effective ratio of volume to container size. So we're having to determine, do we need to replace volume or do we need to adjust the volume? The container size, meaning your vasoconstrictors and so on. And then rapidly transport the patient to the most appropriate facility. Obviously, if you're dealing with a trauma patient and this patient's hemorrhaging, we're going to need to transport them to a facility that is capable of managing this patient in an OR setting. However, if you're long distance away from that area that can maintain that patient in an OR setting and your patient is sick on you and they're not doing well, then obviously go to the most appropriate close facility. Then you begin stabilization of this patient, and then we can, at that point, start inquiring on how to possibly get this patient to the appropriate location. All right, so red blood cell oxygenation. So adequate oxygenation of the red blood cell is required for adequate oxygenation of the tissue. Got tongue-tied, sorry. That's kind of self-explanatory, okay? If you've been in medicine more than about 2 weeks, you understand the purpose of blood and the purpose of oxygen, right? So our goal in the EMS setting is to make sure, one, that the patient has a patent airway and that the patient is receiving the appropriate amount of oxygen via that patent airway, whether we establish a patent airway or the patient themselves has a patent airway. Ventilation should be supported with oxygen to maintain a SpO2 level greater than 94%. But here's a drawback to this part right here. If your patient is hypovolemic, especially in the presence of a hemorrhage, you need to place that patient on 100% FiO2. That's your fraction of inspired O2. That's pretty much what you set your flow rates and stuff at. You want to make sure that patient is receiving as close to 100% oxygen as needed. What that's going to do is ensure that every bit of the available red blood cell is saturated with oxygen so that we're delivering as much oxygen as possible to this patient. Another thing was we want to make sure that we start monitoring our end tidals on this patient. If you know me, you know I'm a huge end tidal person, and I think that it is very underutilized in the pre-hospital setting. Your end tidals can tell you a lot. If you have end tidals less than about 25, they say it's indicative of having poor perfusion. So we can start tailoring our treatment towards looking at those end tidals, not just necessarily looking at those blood pressures, aka your MAPs. All right. And also, if needed, the paramedic can assist ventilations with positive pressure. So if we determine that this patient needs an airway, we establish an airway, we provide positive pressure, or we're just giving them the old school BVM. There's nothing wrong with ventilating a patient that needs to be ventilated. You also want to make sure you clear any obstructions in the airway, whether it be debris, vomit, and whatever. If the patient has signs and symptoms of a tension pneumothorax, we want to remedy that. Needle decompression. And then obviously your open chest wounds, we want to make sure we close those with those occlusive dressings, monitor them, burp them as needed. And then your unstable chest walls. Now, unstable chest walls is something that kind of floated in and out on how to manage these patients. You had sandbags you'd put on them and saline bags you'd put on them. At that point, it's just follow your local protocols and your guidelines on that. I've seen saline bag taped to the chest. It kind of helps associate that and treat it pretty well. However, if you do that, remember what a flail segment is and what an unstable chest wall is. And remember, there's always that complication of possible furthering injuries when you apply that. So just take that in consideration. Don't not treat the patient. Just take into consideration the purpose of treating the patients and the effects of treating that patient, both good and bad. All right, ratio of the volume container size. So the second requirement in maintaining adequate oxygen carrying capacity is that the container be full of fluid. So remember, we look at ours as our body, mainly our our vascular system as a container and our blood as the fluid inside that container. Now, they have to be at their normals to maintain that pressure. Remember, pressure is the driving force behind delivering oxygen to the body. So we have to make sure that the container size is appropriate for the amount of fluid there for that capacity of carrying that oxygen. Sometimes we have to be ready to utilize vasopressors as needed, especially when the shock state is not associated with hemorrhage. So now use that last phrase very, very loose there. Just because a patient's hemorrhaging does not mean that you're not going to give them a vasopressor. It just means that's not going to be your initial go-to to treat that patient. If we're giving them fluids or blood or whatever we might be doing and they're still losing that pressure going down, there's nothing wrong with tightening that vessel up as you replace that fluid volume. But what they're telling you there is don't let vasopressors be your initial out the gate treat this patient with. Okay. And then also you got like your distributive shock in these patients. This isn't necessarily a fluid problem. It's more so a vessel problem or a container problem. So we can add fluid to them. And yes, we are going to add fluid to them because that's the easiest right out the gate method to increase the blood pressure secondary to hypotension or secondary to hypoperfusion. However, we can add fluid to this patient all day long. What is fluid not going to do? It's not going to carry the blood. Get down to the grind of what's going on with the patient. They have decreased amounts of oxygen. So what is fluid not going to do? Carry oxygen. It's going to fill a void, but it's not going to carry oxygen. And we're also going to learn later on that there's some nasty side effects to pouring lots of fluid to people. We make them unable to clot and so on. So being able to differentiate the actual cause of the shock and the treatment of the shock is very important. If fluid's not a problem, don't pour them with fluid. Be ready to get aggressive with the patient pretty early and throw them on some vasopressors. Note that vasoconstricting drugs are not recommended to treat patients in hypovolemic shock, as it says right here. It's just not first line. So be careful how you read that book in that chapter right there, or in that section in the chapter. It's not saying don't use it, and if you just loosely read that book, that's what it says. But it's saying don't use it. It's not saying don't use it. It just says it's not your first-line treatment for it. All right, fluid resuscitation in shock. So almost every patient in shock requires some form of volume expansion as a part of that resuscitation. So all your patients are going to get fluids. Now, determining, the cause of shock or the form of shock is kind of going to be the determining factor on how much fluid that patient gets. So the days of us just pouring fluid to a shock patient till we got the BP we wanted are over. So if you're still functioning as your EMT and you're watching your paramedic partner, I urge you to kind of call them. Hey, at what point do we probably need to consider something else? We done give this patient 7 liters of fluid. Are we really benefiting this patient any? So the drawback to, not the drawback, another hindrance to is we got to understand what fluid is best for that particular patient. The selection of IV fluid for initial volume replacement varies according to a lot of your medical direction. You've got most 99% of them are going to tell you right out the gate, just go normal saline. And we're going to talk about these different crystalloid solutions here in a second and how they benefit and how they harm. But majority of them are just telling you right out the gate normal saline. You've got some that are done that's gone in a little deeper and they look at it and they say, all right, well, normal saline's okay, but if we got LR, let's go with LR. And they'll used to tell you all the time, well, you can't give LR behind blood or you can't give blood behind LR. You can, you just can't run them together, is what that's saying. In the pre-hospital care, the most common emergency requiring fluid replacement is the loss of volume caused by hemorrhage or dehydration. The type of fluid replacement is strictly dependent on the patient's needs. All right, so the two types of fluids that you're going to see in your EMS setting, you have crystalloids and colloids. All right, so starting out with crystalloids. Crystalloid solutions are created by dissolving crystals, hence the name crystalloid, such as salts and sugars in water. Now, what do we remember about salts and sugars? What follows salt and sugar? Fluids, right? So these solutions do not have as much osmotic pressure as colloid solutions do. And that's because of colloids, they're the components of colloids are larger, so they're not able to transfer across those membranes as easy. That's kind of how it changes that membrane osmotic pressure. They can be expected to equilibrate more quickly between the vascular and extravascular spaces. However, 2/3 to 3/4 of the infused crystalloid fluids leaves the vascular space within about 30 minutes to an hour. Now, that's not something that we worry about in the EMS setting because hopefully we're not dealing with a significant trauma more than about an hour. However, you got to think about it. Yes, our care ends when we drop that patient off, but the treatment we provided for that patient throughout that transport still affects that patient after we drop them off. Okay, so an easy way to look at what I just told you is it requires 3 milliliters of a crystalloid solution to replace 1 milliliter of fluid body loss or body fluid loss. So if you're looking at this and just for simple math purposes, and you walk in and somebody slit their wrist or something like that, and they've got roughly 100 cc's of blood out on the floor, volume expansion wise, it's going to take 300 milliliters of this crystalloid solution to equate to that 100 milliliters of estimated blood loss that they have there. Like we said earlier, infusion of large volumes of crystalloids may result in hypothermia because, yes, we have fluid warmers in our ambulances, and I know a lot of them are not equipped with it, so it's not your fault. I'm not faulting you as EMS providers for that, but we try our best to keep the back of our ambulances warm, but usually we don't have the fluid warm enough. So we're infusing large amounts of fluid. We run the risk of having hypothermia. Well, that's one of the triads of death in a trauma patient is hypothermia. We want to make sure that we keep these patients warm. And what's it matter that we got the heater blowing in the back of the truck if we're pumping cold saline inside of them? You also got to worry about altered coagulation. Like I said, we start preventing the body from doing its own defense mechanism and trying to clot off and prevent further bleeding. And you have your hyperchloremic acidosis. And that's what that means is you pretty much threw that patient into an acidotic state because of the large amount of fluid that you gave them that was of an acidic state. I strongly urge you to go look at normal saline and look at LR and look at the pH difference in them. pH difference in LR and normal saline is astonishing, in my opinion, on why do we still use normal saline for initial fluid resuscitation when it's so acidotic compared to LR. Now, obviously, there's better ones out there. You've got some that is completely neutral on the pH, so they're like a 7.4, and that's your Plasma-Lyte. But those are relatively expensive, and you don't see them much in the pre-hospital settings anymore. All right, so more is your hypertonic saline. So this was a question that I got asked not too long ago by a student in class. What's the difference between hypertonic and hypotonic? And we've done a brief talk about them a little bit in class, but I knew we were coming to this section right here. So if you look on page 1323, we talk about hypertonics. And very briefly in that same paragraph, we talk about hypotonics. Hypotonics are not utilized in fluid resuscitative measures. Hypertonics can be, but you got to be really, really careful with them. Okay, so a hypertonic solution, they have a higher osmotic pressure than the body cells do. So what does that mean? It pulls fluid out of the cells into the vascular space. So it does a great job removing fluid out of that interstitial space and those cellular systems and brings it into the intravascular system to increase that pressure. But the drawback to that is you pull fluid out of those cells. If that doesn't need to be done, we don't really need to do that, if that makes sense. So these include D5, half normal saline, 3% saline, 5% saline, 7.5% saline, and it actually goes up. I've been in some neurological ICUs and seen 21% salines. You have D10 in water, 5% dextrose in LR, 5% dextrose in normal saline, 5% dextrose in half normal saline. These are actually fluids you're probably not going to see in your standard pre-hospital ambulance. So key thing to remember about hypertonic, how does hypertonic work? They have a larger or a higher osmotic pressure than the body, so therefore they pull fluid out of the cells. Well, if hypertonics pull fluids out of the cells because of a higher osmotic pressure, what about hypotonic fluids? Hypotonics, and now you see why you never use those, hypotonics actually have a lower, and therefore it pulls fluid out of and puts it into the cells. So a silly way I was told, hyper goes, sucks it in, hypo go boom. Hypo pushes fluid into the cell and it actually causes cell to lysis and split. All right. Now, the ones that we use pretty much daily. You have your LR, your normal salines, and this is what we call isotonic. So hypotonic, push fluid into the cell. Hypertonic, pull fluid out of the cell. What do you think iso means? It's in the middle. It's neutral. It kind of just leaves it where it's at. Okay. Lactated ringers, normal salines, like I said, are your common ones. Your LR is a well-balanced solution that contains many chemicals found in the human body right now. It contains sodium chloride, small amounts of, potassium, calcium, and roughly about 28 milliequivalents of lactate. Now, not to get off on a tangent on this, people are like, why do you want to give lactate to a patient that is already in an anaerobic metabolitic state and they're producing lactate? Easiest way to explain that, they're not the same thing. So that's a different topic for a different day. You're also looking at this as LR's got a closer to more neutral pH than normal saline does. 1/3 of the infused solution remains in the vascular system over about an hour. Next, you have your normal saline. Now, normal saline contains about 154 milliequivalents per liter of sodium. It does not have any buffering capabilities. All right, so it does not have the ability to buffer like that lactate up there did. So we actually, if not careful, aggressive normal saline, we're actually kind of pushing our patient down that pH line a little bit and making them worse off. As with lactated ringer solutions, nearly 1/3 of it, just like we said above, stays in the vascular space after about an hour. Next, you have your glucose containings. That's your 5% dextrose in water, not saline, water. That's your D5W. Then you have your D10Ws and stuff like that. Now, a lot of times you see, especially in your ERs and your critical care transports and stuff, they do all their vasopressors mixing in D5Ws or D5s just because they tend to not break the medicine down as much as. Now, that's a very, very loose way of describing that. It actually goes a little bit further into that. If you see in the ER settings while you're doing your rotations, people are going with a D5, that's why. Those medications hold up better than they do a normal saline. All right, colloids. So colloids. The easiest way to look at colloids is it's what we have in our body. Now, there are, obviously, right out the gate, you can think of your packed red blood cells, your whole blood, your plasma, your platelets, and stuff like that. Those are forms of colloids. There's other also blood substitutes that we also use, such as like hetastarch and stuff like that. We'll talk about those here in just a second briefly. So a colloid solution contains large molecules. These are usually protein that cannot pass through the capillary membrane. So what that means is those proteins or those molecules that make up that particular substance, in this situation blood or so on, is unable to pass across those capillary membranes. So therefore, they hold in the system longer. They exhibit a more osmotic pressure and remain within the vascular compartment for a considerable amount of time compared to our crystalloid solutions. Some examples is whole blood, packed red blood cells, plasma, and you've got different forms of plasma. You got LP, which is liquid plasma, and then you got FFP, which is fresh frozen plasma, and then you got your plasma substitutes. Now, like I said a while ago, you got those synthetic colloids like hetastarch. But usually your Head Starts, you don't see them utilized much, mainly, to be honest with you, because of expense purposes. So whole blood is rarely given in the United States in the management of shock in the ER setting, mainly because it's not really available. Now, whole blood is definitely more beneficial to the patient than, say, giving them packed red blood cells or so on. So quick, without going into it in depth, what's the difference between whole blood and packed red blood cells and so on? So in order to make packed red blood cells, liquid plasma, and all this, they spin it down and they separate those components. So when you give packed red blood cells, all you're giving are exactly what it says. You're giving red blood cells. So what's the purpose of giving red blood cells? Increase the carrying capacity of the blood. All right, plasma, that's where it holds our stuff like our clotting factors and other things like that. So we'd give that to help clot. Usually what you see is a 1-to-1. 1, so 1, 1, and 1. So 1 liter of fluid, then they'll get 1 liter of blood. 1 unit of blood, 1 unit of some form of plasma. And that's going to vary. So don't take that to the bank. That varies depending on department, facility, or services. But anyway, so whole blood is just what it is. It's whole. Nothing's been necessarily spun down and taken from it. So when we give that 1 unit, we're actually giving a little bit of everything that patient needs when we give that. Again, don't see it done that much, mainly because of the expense, and the blood doesn't last as long. So it's got to be utilized relatively quickly. However, right now we're going through blood so rampant due to COVID and all that we're having a hard time even keeping packs in our systems in stock right now. So once you get them in the hospital, one of the primary things that they're going to do is they're going to get what we call emergent release blood, and we'll talk about that briefly here in just a second. All that is your universal donor blood. So your universal donor blood means that you can donate that blood if you're that particular blood group, which is O blood. You can donate it. It doesn't have those antigens that will cause that hemolytic reaction. So pretty much any patient can receive that O blood. But once they get in there, they might get that O blood right out the gate as an emergent release blood, and then they're going to type and cross-match. So what that means when they type and cross-match is they'll take blood from the patient, they'll send it to the lab, and they'll determine that patient's ABO group and their RH type. So that's your A positive, AB positive, A negative, and so on. Excuse me. So that's what type and cross-match is. Obviously, we want to give you the blood that your body already has. So if you're AB, we want to give you AB. If you're A negative, we want to give you A negative. If you're O positive, we want to give you O positive. We want to give you what your body currently is adjusted to. But in the event of an emergent situation, you can give them your O bloods. All right, so theory of fluid flow. I kind of like this. Very small section in this chapter, but I like it. Used to in paramedic school, we used to have the IV Olympics, which was pretty neat. And it would just blew people's mind, or blew students' mind, how this right here works. So right now, everybody's like, man, I'm going to get a large bore IV. We're going to take that 14 gauge, and we're going to throw it off in there, and we're going to pour some fluid to it. Well, they're going to take that 14 gauge, it's 2.5 inches long, that we normally use for needle chest decompressions. They're going to pour it in there, and then old dude that's sitting on the seat beside them is going to throw in a 16 gauge that's 1 inch long and dumps that fluid faster than the 14 gauge. So, and here's why. So fluid flow through a tube is relative directly to its diameter up to the 4th power and inversely related to its length. All right, so Ben, what did you just say there? What that means is, really broken down for you, is the fatter the catheter, the shorter the catheter, the faster it flows. So another way that we can increase this flow, or hold on, before I get there, let's back up a little bit. So some other factors that can affect this is, one, the patient's vein size. Obviously, we're not going to go in there and start dropping in IVs that we know that are not going to fit in a patient. Okay, so their vein size, their current pressures inside that. So obviously somebody with super elevated blood pressure is going to have different flow rates than somebody with super low blood pressures. They'll tell you, that doesn't really affect. It does, okay? So another way that we can increase the amount of fluid that we get to the patient is we choose, one, larger diameter, shorter catheter. We can also pressurize the system, and we can put pressure bags on them. Now, granted, Most of your EMS agencies do not have pressure bags, but they do have blood pressure cuffs. Now, with that being said, that is not the correct way to do it. Do we do it? Absolutely. The correct way to do it is to place a manufactured pressure bag on the fluid. And you'll pump that bag up to 300 millimeters of mercury and administer your fluid. Just be careful when you're doing that. You can dump a lot of fluid really fast. When aggressive fluid resuscitation is indicated, like I said, short, large diameter catheters, warm fluids flow faster than cold fluids because the colder they are, the more they have a higher viscosity. And viscosity, look at that as thickness, okay? So warm fluids flow faster than cold fluids. And then keep your IV tubing as short as possible. So sometimes when you get in the ER, you've ever seen, they'll call them in the ER, they'll call them their surgery lines. And it kind of goes completely opposite of what you think. Think surgery, ooh, I need lots of fluid, fast. We're thinking emergent surgeries. Then you unroll this tubing and it's like 13 foot long. It's got 16 connects to it. Well, you got to think in that OR settings, we got to move a lot of stuff away from the patient so all these staff members can get to the patient. So when you want to pour a lot of fluid, short lines, pressurize the system, short, fat catheters. All right, so the key principles for managing shock. So as paramedics, we should follow the key principles and plans for managing a shock patient. Step 1, control life-threatening external bleeding. If they're sitting there pouring blood out faster than you can put fluids or blood back in them, you are serving no purpose. Now, granted, there's going to be times where bleeding cannot be stopped, i.e. internal hemorrhage and so on. There's no excuse to at least slow the bleeding down on external hemorrhage, especially nowadays since we have tourniquets and you have some services that are moving into like junctional tourniquets and stuff like that. So the whole goal is to try to limit that external bleeding as much as possible. We're going to establish and maintain an open airway. So when we establish and maintain that open airway, that's not saying tubing them, that's just making sure there is a patent airway. Tube them if needed. Administer high concentrations of oxygen. Assist ventilations as needed. Kind of self-explanatory there, guys. Initiate IV fluid replacement if appropriate. Okay. Sometimes we have to be ready to go. You know what? I can pour fluid to them. It's not going to fix my problem. Let's shrink this system down a little bit. Or let's increase the effectiveness of the pump, i.e. cardiogenic shock. Determine the cause of shock and manage it appropriately. Maintain the patient's normal body temperature. That's a big drawback for us in the EMS setting because we have a hard time doing that. That's easy for us to do in the ERs because we have all this fancy equipment that helps keep a patient warm, and we've got all these people that can do one particular thing at a time and then cover the patient back up. Back of the ambulance, that can be difficult to do, but try to maintain body heat as much as possible. We want to transport the patient in a supine position. We want to provide spinal motion restriction if indicated. Notice that does not say long spine board. It just says spinal motion restriction if indicated. We want to monitor the patient's cardiac rhythms because we know going back from the first video we did, one of the major drawbacks to shock is cardiac dysrhythmias. Now think about it. How do we treat cardiac dysrhythmias that are shock related and cardiac dysrhythmias that are not shock related? There is no difference. We treat them the same. We want to monitor end-tidal CO2s. We want to look at oxygen saturations. Remember, our end goal is to maintain a SAT of 94% or higher. Frequently reassess the vitals en route to the emergency department. Go back to that narrowing pulse pressure that we talked about. Go back to those maps that we were talking about. How do we know our treatment is effective if we're not monitoring the vitals continuously, mainly trending them? That is how we associate success of the treatment and the effectiveness of the treatment is those trendings. All right, so breaking down and talking about individual shocks. Obviously, probably one of the most common shocks that we run into in the EMS setting is hypovolemic shock. In addition to the general management appropriate for all patients in shock, certain management guidelines are tailored to individual shock categories themselves. Like I said, hypovolemic shock is usually probably our most common form of shock in the EMS setting. However, I think sometimes a lot of shocks are overlooked because they're not obvious. And that goes back to that first video that we did where we talked about the subtle changes in the early stages of shock. So, hypovolemic shock. Management is not completed until the volume is replaced and the cause or causes are corrected. So, we might have the patient looking better when we arrive, but that does not necessarily mean that management was successful. That just means we were on the verge or in the process of making management successful. If, let's say that this is a hemorrhage problem, that patient is not fully managed until that hemorrhage has stopped. Crystalloid fluid replacement is done in cases of simple dehydration and volume replacement. Because hemorrhage and definitive surgery and critical care transport and post-operative rehabilitation is really the definitive or end-all, say-all for that patient. In our settings, minus some vasopressors, fluid's about all we got to medically treat this patient. However, stopping that external bleeding if they have it is going to be the deciding factor on that patient's outcome. Now, fluid resuscitation volume should be titrated to the patient's mental status. So again, remember, I urge you to get out of this. Let's see how much fluid we can get in our patient. Let's see if we can turn them to Kool-Aid. We're going to titrate our fluid volumes to meet this patient's mental status needs and maintaining a MAP of about 60 to 65. Now remember, I've told you that's going to be dependent on what literature you read. I like 65 because out of all the literature I've looked at, 65 is usually right there in the middle of the differentiation, so to say. So I like the 65. When external hemorrhage has been controlled and the patient exhibits signs of shock, we can start giving 250 milliliters up to 1 to 2 liters of fluid volume replacement until we start getting that increase in mental status, dropping of the pulse rate, increases in blood pressure, and so on. Now, I know there is the formula, 20 milliliters per kilogram of fluids, and there's nothing wrong with that formula. You're going to see that on your standardized registry testing and stuff like that, but we got to get out of the habit thinking that, oh man, that I did the formula and it says that they got to get 3 liters of fluid. No, it says that they could use up to 3 liters of fluid possibly. That's not saying they're going to get 3 liters of fluid. So, anytime you're giving fluid boluses, you want to make sure you're listening to lung sounds and make sure we're not having any form of pulmonary congestion leading towards like pulmonary edema and so on. Now, in the event of non-traumatic hypovolemic shock, such as extreme forms of dehydration, technically, if you want to be honest, looking on it, you're looking at like the sepsis type patients where you've got that interstitial fluid and they're pulled out. So technically the volume inside the intravascular system is down. So it meets hypovolemic definition. You can infuse crystalloids beginning at about 30 milliliters per kilogram to a maximum of 1 liter over about 15 minutes. Now, that's a good bit of fluid, so be careful with them patients when you start doing that. Now, notice it says can begin with. That does not mean that the patient is going to get that. Assess your patient throughout your treatment to attest the effectiveness of your treatment. Be careful with fluids, okay? And do not be afraid to pull the trigger with vasopressors as needed. So I'll take my hat off for just a second on the instructor side and kind of tell you what I do a little bit. So let's just say in a perfect scenario, I got an intubated patient and taking them I'm flying them from one location to another location for sepsis. And right now, a common sepsis protocol throughout a lot of our facilities in our area is 30 milliliters per kilogram fluid boluses. And I'm like, goodness gracious, that's a lot of fluid for this little lady sitting right here. So what I'll go is I'll go in there and I'll make sure that the patient's on the end-tidal. Again, we're intubated. I'm making it best case scenario for us right now. They're intubated. And what I'll do is I'll lay the patient flat and I'll do a passive leg raise on this patient. So if I do a passive leg raise on this patient, that's roughly equivalent to about a 200, 250 cc fluid bolus. And I'll watch my end-tidals. If my end-tidals increase with that passive leg raise, then I'm thinking to myself, you know what? They probably are fluid down. So I'll give them a little bit of fluid. Or I'll start the fluid bolus process. If I do a passive leg raise and it doesn't really affect their end-tidals that much, then I'm going to probably go pretty quick to putting that patient on a vasopressor infusion, whether it be epi, norepi, vaso, dope, whatever it might be. I'm going to be pretty aggressive early on in giving that patient a vasopressor. So again, that's how I do it. I'm not saying that's what you're going to be testing on. That's how you need to do it. And that's just understanding the physiology of what's taking place. When I do that passive leg raise, that fluid returns down. We increase that CO2 output because we're increasing the amount of fluid coming back to the core of the body. So it's circulating to the lungs and outputting that CO2. If I do that passive leg raise and it didn't increase any, that lets me know that, hey, you can give fluids. Obviously, we're not going to do anything. Okay? Because you got to remember, that saline and that LR is not going to transport oxygen. It's not going to transport CO2. So it helps you out a little bit. Cardiogenic shock. So I would probably say that this runs a close second. However, this is where a lot of us fail as EMS providers, is effectively treating cardiogenic shock. Because up to this point, we want to say that shock is low blood pressure and all this. Actually, with cardiogenic shock, you might see some high blood pressures. Remember, shock is not defined by low blood pressure. Shock is defined by hypoperfusion, low oxygen levels at the tissue sites. So remember what I told you about cardiogenic shock. Think cardiogenic shock pump problem. The management of cardiogenic shock focuses on improving the pumping action of the heart and on managing the cardiac dysrhythmias or rhythm irregularities. The paramedic should initiate fluid resuscitation, again, early on this patient, but limit that fluid resuscitation. Because if this is a left-sided heart failure, what are we going to do to that patient? We're just going to really exacerbate the problem that's already at hand. So be careful pouring fluid on this patient. So they say in your book, and I've actually heard this in other literature, a good 250 cc fluid challenge on these patients. And notice what that is, fluid challenge. So that kind of makes you look at it a little bit differently. What that's saying is let's try 250. If we get some improvement, then hey, we can work off that. If not, then I need to stop fluids. So 100 to 200 milliliters of a volume expanding fluid challenge. Fluid resuscitation should be initiated on these patients as long as the patient has no crackles in the lung fields or anything that's indicative of pulmonary congestion, i.e. pulmonary edema. If the patient improves, fluid therapy can be continued. But again, cautiously. Anytime we suspect cardiogenic shock, we need to continuously monitor everything that we already know is going on with the patient, but yet we still fail to do in our settings. And when I say we, I'm including myself into that sometimes. The paramedic should assess lung sounds often. If the patient starts showing signs of increased pulmonary congestion, pulmonary edema, they start getting that frothy fluid, so on, immediately stop the infusion and start taking care of that patient on that aspect. So again, this is where we usually fail on cardiogenic shock, is we're like, oh crap, that didn't work. Drive fast, let's go. Now granted, congestive heart failure, pulmonary edema, that is actually one of the concepts on think about the PONS, position, positive pressure, oxygen, nitro, drive, or diuretics, okay? but that doesn't mean treatment stops there. So we treat the patient, treat the issue that's causing the shock, because if we fix that issue, that pump problem, we're going to fix the shock problem. Okay. So drug therapy for cardiogenic shock varies according to the actual cause of that cardiogenic shock. It may include vasopressors like your norepinephrine, your epinephrine, and your dopamine. Inotropic drugs. I love how it finally took your inotropic drugs out of there, because, you know, when we think of just strictly an inotropic drug, that's your dobutamine. It really has no pressor effect to it. All it does is stimulate the beta 1 aspect of the heart, and it increases the contractility of the heart. So anyway, your vasopressors, so your epi, norepi, dopamine, your inotropic drugs such as your dobutamine, Milrinone, and stuff like that. Then you have your antidysrhythmics. If the patient is in need for them, give them to them. Okay, whether that be your mags, your amiodarones, your lidocaines, whatever might be the cause of those rhythms that is requiring that antidysrhythmic. Obstructive shock. Now, some common causes of obstructive shock is your pericardial tamponade, tension pneumothoraxes, and your pulmonary embolisms. Now, one of those, very easy to treat, right? Tension pneumothorax. Your pericardial tamponade and your pulmonary embolism, however, in the pre-hospital settings, is very, very difficult to treat. Obviously, the goal for pre-hospital care is to identify and relieve the obstruction of that flow. For pericardial tamponade, this was asked by Coy yesterday. How do I treat pericardial tamponade? I mean, I can't do a pericardial effusion. You're right, you can't do it, and I really probably wouldn't want to do it, to be honest with you. I'd like to do it one time under the guidance of somebody there that knows what they're doing. But so I was like, well, that's a good question. So, but think about what we have to do here. So think about what's happening in pericardial tamponade. What we're doing is we're compressing those empty ventricles. When we release that ventricle, or that ventricle goes through systole and contracts and pushes blood out, it kind of puts a squeeze on that heart, and it doesn't let it fully expand back out. So we're kind of decreasing that cardiac output because we're decreasing that stroke volume that's leaving that heart. So how do we fix that? We pour some fluid to them. We force that volume into that heart, so to try to expand it out as far as we can go and push it out. Tension pneumothorax, simple. All right, dart them, chest tube them, move them out the door. Usually when we do that, the emergency's over at that point. It usually works relatively well. And then your pulmonary embolism. Now here's where we do have an issue, because really the only treatment for the pulmonary embolism is going to be your fibrinolytic therapy, or surgical consult for your thrombectomy. So distributive shock. So this is another shock that's commonly seen, and really two of these three that we're going to talk about. So neurogenic shock, anaphylactic shock, and sepsis shock. We're seeing a lot of septic shock now. And again, we kind of fall this under cardiogenic shock as far as treatment. We actually kind of let this go to the side. And as pre-hospital healthcare providers, we fail a little bit on treating these patients effectively. And when I say effectively, timely. Okay. So neurogenic shock, not to be confused with spinal shock. That's two different things. Neurogenic shock is a disruption between the communication of the brain and the vascular system. Now, is it more to it? Absolutely. It goes a lot deeper than that. But the easiest way to define that is the brain doesn't realize there's a problem, so therefore it cannot cause or cannot put into motion the remedies for that. So real quick, blood vessels dilate out and the body senses a drop in the baroreceptors, and it causes all this release of your hormonal release, your RAS system and all that, and we have vasoconstriction. That's when we have an intact network of communication. When there's a break in that network of communication, we have that vasodilation. The baroreceptors do their thing, but there's nothing telling the brain what's going on. So the brain is not able to kick the body into a response mode. The management of neurogenic shock is similar to the management of hypovolemia. We're going to pour fluids to this patient. Again, monitoring them just like you would any other patient you're pouring fluid to. But do not be afraid to put vasopressors on a neurogenic shock patient. Now, some forms of neurogenic shock, or when I say some forms, neurogenic shock, one of the signs of neurogenic shock is low BP with, as your book calls it, bradycardia. Again, remember when I mentioned that to you in last slides or the last video, use that word bradycardia relatively loose. If we've got a blood pressure of 70 systolic and you got a heart rate of 60, that's not right. Your body should be saying, hey, I need to pick up my heart rate, because how do we control cardiac output? Increase heart rate, increase stroke volume. Which one can we do it the easiest? Heart rate, right? So for us to have a blood pressure of 70 and a heart rate of 60, that doesn't seem right, but it's 60 bradycardic. Let's say 64, just to get off those people that like to ride the line. 64. Is 64 bradycardic? No. But should it be 64 with a blood pressure 70? No. So be ready to kind of think outside the box a little bit and treat these patients. I know the body should be compensating by increasing pulse rate at this time. So let's put fluids in there and let's be ready to put some vasoconstrictors on this patient so we can constrict it down. Let's utilize that heart rate of 60, which is fine. Let's utilize it, but let's make sure that the pressures at the end outside that pump, that afterload, is where they need to be so we can maintain that perfusion. Next, we have anaphylactic shock. This one is probably beat into every paramedic student's head, how to manage anaphylactic shock. It's one of those that just kind of you open your mouth and word vomit on how to treat this patient. The immediate treatment for it is, in an anaphylactic shock, is going to be your IM administration of epinephrine. IM sub-Q, depends on what your protocols tell you. I'm telling you, I'd go straight IM. Your EpiPen is IM, so why would we give our medication sub-Q? Go IM. I've actually seen in the ER settings on severe anaphylactic reactions and anaphylactic shock, they give the medication IV push. Just be careful doing that. I don't recommend it. I say go IM unless your protocols allows you to do that. We're going to give crystalloids solutions because we're going to have this, due to this histamine release, we're going to have this massive vasodilation. So we're going to give crystalloid replacements to fill the tank, and we're also going to be ready to give this patient vasopressors if needed. I mean, we give epi-IM so that we can get the bronchodilation and vasoconstriction. So if we still need it following fluid and epi-IM, what's wrong with giving an epi infusion, low dosing? Again, follow your protocols on that, but be ready to be aggressive, because nothing that I just said is outside your protocol. It's just utilizing what you already know is going to work to your benefit. And then you're going to have your, you're going to have your antihistamines, both H1, H2s. It depends on your protocol. So your Pepcids and your Benadryls. And then you might actually have your steroids, such as your Solumetrol. All right, distributive shock. This is, septic shock, part of distributive shock. So again, this is one that we're seeing a lot now, especially with the pandemics that are going on. The management of septic shock in the pre-hospital setting can include the management of one, hypovolemia. Now, what we have to understand is we might go in there and go, well, that patient doesn't look hypovolemic. You know, they're not dried up like that. They actually got some swelling. It looks like edema. Okay, you're right. But where is that? It's out of the vascular space. What is hypovolemia? Decreased fluid level in the intravascular space to deliver oxygen. So our goal is to treat the hypovolemic state and to also correct the metabolic acid-base imbalances. Depending on the patient's response to the infection, pre-hospital care can involve fluid resuscitation, vasopressors as needed, and again, don't be afraid to use a vasopressor and to improve this cardiac output. Though patient history is very important, sometimes we have a hard time getting that. So we have to be pretty good medical investigators in looking at our environment that we find these patients in. Again, I'm not throwing any particular career decision in the mud when I say this, I promise, but nursing homes is where I see a lot of my septic patients come in, mainly because, you know, they got the indwelling catheters, and even though they're taken care of like they're supposed to be, that's still a safe haven for a freeway of infection to enter the body. And again, I promise I'm not talking about any any career or any facility in particular. I'm just saying we know areas that run the risk. And the same thing with patient subtypes like immunocompromised patients, such as HIV, cancer, receiving chemos, and stuff like that. They just have that increased risk of acquiring a pathogen that can cause a severe infection. Patients with adrenal insufficiencies associated with sepsis, like so a patient that's been sick for an extended period of time that is now septic as all get out. You might start seeing some corticosteroids be administered to this patient. Because you got to think about it. What's happening the whole time this patient's sick? We're sitting here and we're burning those adrenal glands up, trying to dump all these catecholamines out, these epis and norepis and these other some more hormones, so that we can maintain this normal perfusion status for the body. Well, we're going to the point where we've drained them. The adrenal glands can't keep up with this anymore. So we might actually have to go in there and give these patients some corticosteroids, such as hydrocortisone IV, not creams, hydrocortisone IV, and that's usually about 100 milligrams, and that's what we call Solu-Cortef. And another one you can give is your methylprednisone, which is your Solu-Medrol, and that's usually about 125 milligrams. And again, that is weight dependent on, and are we dealing with a pediatric or are we dealing with an adult? All right, so the integration of patient assessment and treatment plan for shock. There are many complications of shock. Okay, there's many treatments of shock. If you look on page 1329, box 35-3, you sit here and see some of the complications of shock. Even if we're treating them appropriately, you have acute renal failure. You have acute adult respiratory distress syndrome, ARDS. ARDS is very common in shock syndromes. Hematologic failure, multiple organ dysfunction syndrome, sepsis, acute respiratory distress syndrome, death of the organs, death of organisms, good organisms inside our body, and then DIC. So the patients can, start bleeding out more than they're already bleeding out in the events of, like, your hemorrhage patients. So the goals for pre-hospital care for this patient include severe hemorrhage or shock, is rapid recognition of the event, aggressive treatment. Okay, be ready to ride the line of what's uncomfortable for you, but yet still function in what you know is appropriate. Initiation of treatment and prevention of additional injury. Rapid transport to the appropriate medical facility by ground or air ambulance. Advanced notification of the receiving facility. So we can actually sit here and treat this patient appropriately en route, but if we don't have a receiving facility awaiting this sick patient's arrival, we're setting them back. The paramedics should follow the guidelines established by their local protocols and their medical director in determining the appropriate pre-hospital level care for patients and in identifying the appropriate medical facility for this patient's transport. All right, guys, so that's pretty much chapter 35. So if you have any questions, please feel free to call me, text me, message me any way you need to. And if you got any questions on maybe going a little bit deeper in some things, I'll be more than happy to. But everything we talked about is kind of what you'll need to know for test and registry purposes. However, I would love for you to ask some questions to get a little bit deeper into it, especially like your CO2s and stuff like that. All right. Have a good day.